Welcome everyone to this ESICM webinar on Coma of unknown origin. This webinar has been organized by both the Trauma and Emergency Medicine section and the Neurointensive Care section. My name is Claudio Sandroni. I'm an intensivist in Rome, Italy, and chair of the Trauma and Emergency Medicine section. Thanks to ESICM for having supported this webinar. We have two guests here. We have Dr. Sojin Park. She's a neurointensivist and associate professor of neurology and biomedical informatics at Columbia University Hospital in New York, USA. Welcome, Sojin. And
Hello,
we have Raymond Helbock, a neurointensivist, also associate professor of neurology at the Medical University in Innsbruck in Austria. Welcome, Raymond.
Hello, everybody.
Thank you both for being here. So, coma of unknown origin can represent an important issue, both in emergency department and in hospital, and both in general wards and in ICU. It has a very high mortality, and main causes are split at almost 50-50 between the neurological and the extra-neurological causes. And so we split our presentation and in two parts. One will be focused on new neurological causes and the other one in direct neurological causes. The first to speak will be Raymond Helbeck. It's my pleasure to welcome him here and give floor to him. Please, Raymond.
Thank you very much for the introduction, Claudio, and thanks to the organizing committee of the European Society of Intensive Care Medicine to talk about such important cases. And I hope that while discussing the cases, there's going to be a huge learning effect for all of you who attend the meeting. So I'm going to present the first case. This is a 39-year-old woman, which was admitted to the surgical department due to a bike accident. You see the X-ray, the broken leg. But this patient had a history of pulmonary embolic events and was on anticoagulant treatment. She had a morphine dependency, quite high dose of morphine substitution. She was diagnosed of hallucinations, so she was also put on antipsychotic treatment, and she was dependent on benzodiazepine treatment as well. Besides that, chronic hepatitis C, endocarditis, and morbus Crohn. She got operated one day later, and the extubation and the operation was actually uneventful, but the next day she went into respiratory insufficiency with desaturation. The cardiac arrest team was notified, and she was admitted to the ICU. And she was described as being a DOC patient, so somnolent, disoriented. There was no abnormality of focal neurologic signs in terms of the brainstem reflexes or motor deficits, sensory deficits, and the Babinski sign on the right side was not possible to test, but the left side was negative. But she had jerks, and I would like to share this video with you. Because I was actually consulted to see the patient, and I would like you to recognize the movement, which you can see in the whole body, but mostly on the legs. Just look at this area, and then we can, so you see these jerks, and we define them as myoclonus because they are not regularly happening. And if you see that patient, you see that if you see the movement, you see that sometimes the myoclonus is only on the extremities, sometimes, as you can see here, in the whole body. And as I told you, she was intermittently open the eyes. It was sometimes possible to talk to her, quite interesting, but she was not orientated, and then she drifted away. And if you look at the legs here, you see always these jerks. Now, pointing out to the EG, you see epileptiform discharges, and you know that these myoclonic jerks are of epileptic origin, which is quite important, and you see these generalized patterns, and then also focal patterns. So this is the patient, and you know all the medication of the patient. So this was quite interesting for the differential diagnosis of myoclonus and the decreased level of consciousness. So what we did first is brain imaging, and this was actually already done before. And you see the brain heads, so the brain CT scan. There was no abnormality seen on this screen at that time. We did not go for MRI scanning because also my impression was that it is not possible. It's not mandatory at this time. We went for a CSF analysis, also to work up the differential diagnosis of myoclonus of unknown origin, and you see the CSF results is normal. It was a bloody CSF due to the puncture, but there were no cells after correction, normal protein, and also the anti-neuronal antibodies. So for which in German you might recognize all these important antibodies, they were negative in workup. As you know, or as I told you at the beginning, the patient was on low oxygen levels, so desaturated at the normal ward. So we have to think about the differential diagnosis of hypoxic encephalopathy. I can share the data biomarkers like neuron-specific amylase was normal in that patient. SSAPs, we did not go for SSAPs. We can discuss afterwards why. The pupil reactivity was normal, pupil movement was normal, and the imaging, you saw the CT image on the day when everything started was also normal. So the big question is now the diagnostic workup, and if we see these encephalopathic patients with myoclonus, there are many things to consider. It could be vascular, it could be infectious, toxic, autoimmune, metabolic, neoplastic, neurodegenerative, epileptic. And so the thing which we can also discuss here, how to manage that patient. So maybe at this stage, it's important to mention that every other organ function was normal. There was no indirect sign of hepatic encephalopathy or a renal disease being causative. And you also see the EEG image that we don't have the typical encephalopathic EEG patterns. So also no triphasic wave. So how did we manage the patient? Symptomatic treatment for myoclonus. So these generalized and focal myoclonus, clonazepam treatment, either as continuous treatment, which we did at the beginning, and then the oral treatment with 3 times 2 milligram per day. Levetiracetam, also symptomatic treatment for the myoclonus. And as this in total did not sufficiently treat the myoclonus, we added valproic acid, and you see the EEG afterwards. Diffuse slowing, this is not a normal EEG, the slowing background EEG activity, but she was reacting, and actually her level deteriorated a bit, also due to the benzodiazepines we gave to the patient. And 2 days later, the patient was awake, and you see the EEG improved. It was not normal, but we don't see these myoclonus jerks anymore clinically, and not on the EEG. And due to massive hallucinations, she was still treated with neuroleptic drugs. So the question is what the diagnosis is, and I will just go back to that slide. I don't know whether we in the panel have an idea of what the cause of the myoclonic jerks could be in that patient. I can only say the answer is in the slide already, and this is also something we recognized at the beginning, and that's why we actually influenced the clinical course right away, and then only made a symptomatic treatment. Claudio or Sojin, do you have any ideas or any questions we did not, or would you go for any additional analysis I did not mention at this point?
So the patient was on antipsychotic treatment. So, and given that clinical case with a young woman, she is 39, so probably a vascular accident is not particularly likely, even if you cannot exclude it. So we'll probably focus with something which is metabolic, but the blood tests tend to exclude it. So we'll think of something like toxic. I'm not sure.
I wonder about the fracture and if this was an embolic event from a fat embolism. This potential as well.
Okay, so I think very important. So for the fat embolism, CT imaging is rarely a good diagnostic tool. So we might go for additional analysis like MRI scanning. If there could be a direct connection to these generalized myoclonus, this would maybe not be the first differential diagnosis, but obviously we need that in the workup. The other point what Claudio brought up is the antipsychotic treatment, and you realize that she was put on clozapine in a quite high dose as regular dosage treated for the last months. And so my suspicion was that this was an intoxication with clozapine, and 3 days later we got the confirmation that the blood levels were highly exceeding. And when I could talk to the patient 2 days later, she said that she took some medication over the prescribed dose in the last days because she had too many hallucinations. And in the next days, you see 5 days later, so this just happened a month ago in another ICU, which I consulted, you see normal drug levels and also improving the EEG pattern and improving clinically wise. I think it's quite important to discuss about these intoxications and also EEG abnormalities, because clozapine is known to be associated with abnormal EEG findings. And these are mostly slowing, but these could also be epileptic form, it could be focal, it could be generalized. But the important information is that not every patient is the same. So even the drug levels, so this is the mean dose. We had 400 milligrams in our patient. And here you see, on the right side, you can see the drug levels. We had way above 900. That EEG abnormalities can occur in a dose dependency, but also in lower dose levels. And is it important to treat these EEG changes? I would say no. If there is no clinical necessity to do so, it's very important to recognize that clozapine can cause EEG changes. And in case of intoxication of high dose, obviously you have to treat that symptomatic. Valproic acid is the first choice of treatment, and symptomatic with clonazepam as we did before. Other clinical symptoms and signs can include drop attacks or these jerking movements as we discussed, or twitching. So this is actually the end of my first presentation. If there are any further questions, I don't know, Claudio, in the chat, if there are further questions, or whether I should proceed to the next case.
Not for now. I remind everyone that every question can be submitted via the ESIC TV chat. We are looking forward to receiving your questions. You can proceed with the next case. Thank you, Raymond.
Okay, thanks a lot. So in this case, I can again present you a video. And obviously this patient was not admitted in a comatose state, but I think it's important to see also what happened to a patient before he gets admitted with the same diagnosis we're going to discuss about. What you see is a head turning to the right and a gaze deviation as well. And you also recognize a figure 4 sign, all what you can see here is pointing towards a left hemispheric origin of an epileptic seizure, first focal and then secondary generalized. And this patient was in our EEG monitoring unit to find out about potential epileptic seizures. So this is the EEG, and what you already can see here is some rhythmic activity on the left temporal area, which is evolving in time and space, and then generalizing, and then you got the artifacts due to the epileptic seizure, and then status epilepticus. Because what happened is that the patient did not properly wake up, and I think that's very important also educational-wise. An epileptic seizure is a traumatic phenomenon with a sympathetic activation. Usually these patients have a high blood pressure, have a high increase in blood glucose as well, and especially if symptoms take for longer than expected, and we now talk 5 minutes about the convulsion and maybe the disorientation for longer than 30 minutes, then we know that additional changes may occur, including an increase in carbon dioxide, for example, and then causing a disorder of consciousness. We also know that some patients have a bradycardia, the asystole during epileptic seizures. So with these prolonged deterioration, DOC or comatose state, I think blood gas analysis is very important. And although you now know that the patient had an epileptic seizures, usually it's a situation that we detect these patients in a unconscious, maybe comatose state, and then he is brought to the hospital. So we managed this patient first giving lorazepam. This is what you saw in these patients, which we gave the patient first, and then we loaded him with anti-epileptic drugs like phenytoin and levetiracetam. Why phenytoin? I still believe that phenytoin is a very important drug, especially in focal seizures and in seizures with focal origin, although we know that levetiracetam is mostly used as first drug choice in many patients. And the patient, as I told you, did not properly wake up, and that's why we took the patient to the ICU, and that was the EEG. So we see that there is still abnormalities going on, and if for all of you who can read an EEG, this is fulfills the criteria of non-convulsive status epilepticus. So if we now think about the etiology of non-convulsive status epilepticus and the differential diagnosis, you see that the majority is epilepsy-related seizures and then secondary and non-convulsive status epilepticus. But you also know that CNS infections or other causes like symptomatic causes, brain tumor and other focal pathologies in the brain can cause non-convulsive status epilepticus. In our patients, we had brain imaging before. There was no focal lesion, so we didn't have to look for that workup, and also CNS infection was not a very important differential diagnosis in our patient. But what is educational and what is important to know is that if the convulsion or the epileptic seizure directly goes into a comatose state or an unconscious state, think about non-convulsive status epilepticus as differential diagnosis. If we now think what we saw in this EEG, these are the diagnostic criteria for non-convulsive status epilepticus, the Salzburg criteria by Markus Leitinger and Eugen Trinker. So we do have epileptic form discharges. We have a high frequency. This is important, more than 2.5 cycles per second, and this is then directly the diagnosis for non-convulsive status epilepticus. If we don't have that, and if we don't have the high frequency, so if the frequency is lower, then there are other ways how to diagnose, and I think the most important information is that we observe a clinical improvement after a specific treatment. So this qualifies the patient best for non-convulsive status epilepticus. So take-home messages: we need EEG monitoring for non-convulsive status epilepticus. The patient will not give us these convulsions or other ideas what the underlying cause of coma could be. And as I told you, especially the response to treatment is very important. For example, benzodiazepine treatment. So the patient, as I told you, received already lorazepam and 2 anti-epileptic drugs and so on. Also, the question now for the panel is, what would you do next? So you know that the patient is in a non-convulsive status epilepticus, and we already applied 2 doses of anti-epileptic drugs and a benzodiazepine. So would you at this stage repeat lorazepam, for example, or would you use other anti-epileptic drugs, or should we already switch to a 3rd tier therapy, which is associated with mechanical ventilation and intubation with midazolam, propofol, or thiopental? So Claudio or Sojin, maybe you have any idea, or in the chat. It's obviously important if you share your ideas.
So just to summarize your message, so one important message is that phenytoin should be considered when the seizures are focal rather than fairly used drugs as levetiracetam. Am I right?
You might hear other recommendations from other experts. It's still in the recommendation to use as a drug for focal seizures or status epilepticus. My impression is that more and more people use levetiracetam as first line, because very important, if you use phenytoin, you need cardiac monitoring, and there are some side effects that you have to have a proper IV line. And so there are some other parts which are more difficult than just giving levetiracetam. So that's why you might hear different information from different experts. But in terms of effectiveness, we know that the new anti-epileptic drugs are not more effective than the old ones, and I personally also have good experience, especially with persistent or focal status epilepticus, to apply phenytoin as treatment.
Yeah, and as far as the side effects are concerned and the IV line are concerned, we are in the ICU, so this will not represent an issue or a contraindication.
Sure.
Yeah. And another message that came out from your presentation. So if I have a suspicion for non-convulsive status epilepticus, but the activity is, the rate is lower than 2.5 Hertz, the treatment works as an additional step of the diagnosis. So if it responds to treatment, the diagnosis is made, even though the frequency is below 2.5 Hertz. Is that right?
Yes, this is correct. And I think that's very important to communicate in a very easy way, because that's how to diagnose non-convulsive status epilepticus. As we know that there's so many EEG findings which are close to non-convulsive status epilepticus and do not really qualify, and it's very difficult how to deal with these patients. So the clinical response in secondary to treatment, benzodiazepine treatment or anti-epileptic treatment, but it has to be a rapid treatment and a rapid response. We're not talking about a treatment over days. So we are talking about a shot of benzodiazepines. We are talking in case of anticonvulsant, high dose in a short time.
Okay, excellent, Raymond. I think we have to move on and give floor to Sojin Park for her presentation. Thank you, and please remain online for the questions that are coming on the chat. So Sajin will present another couple of interesting cases. Please, Sajin.
Apologies, I thought I was already sharing. So I'm going to talk about two different cases that will also touch upon a little bit of what Dr. Halbach was mentioning. First, I want to mention that I have no disclosures related to either of my cases. The first case is a patient who's 48, has past medical history of diabetes and high blood pressure. And the story was that while he was renovating his old home, he was checking out the premises and partially fell through a broken step, resulting in acute onset of low back pain with radiating symptoms down his leg and numbness of the foot. And on examination, eliciting some weakness of the right knee and ankle plantar flexion. So the diagnosis was of lumbar disc herniation. This is a patient that was managed at another hospital, so I don't have his original scans, but this is an example of what would be seen in a disc herniation affecting the right side. The patient, because of the weakness and the non-resolution with rest, went to surgery. The disc surgery went well, but unfortunately, several days later, he returned with a fever and severe back tenderness in location of the area of the surgery. Further imaging demonstrated by report a lumbar epidural abscess. He underwent a reoperation for laminectomy and washout, and a lumbar drain was placed by neurosurgery with instructions to drain 10 cc's of CSF every other hour. That evening, he reported headache and nausea, and a mild fever was noted. And in the morning, his nurse noted that the patient had arm and leg twitching and a loss of consciousness. So lorazepam 2 milligrams was given intravenously. He continued to have some twitching movements, but they were decreasing. But importantly, the patient did not regain consciousness. And so a surface EEG was placed. This is an example of what might be seen in a similar case. This is rhythmic delta and theta activity with superimposed high amplitude spike and wave activity. Epilepsy there is concerned because of similar findings for non-convulsive status epilepticus. Just the sidebar about non-convulsive status epilepticus, and Raymond really went over this in great detail. Non-convulsive status epilepticus, when it presents with coma, can be refractory to multiple initial therapies. And the refractory status epilepticus that's refractory to multiple anti-seizure medications is associated with mortality up to 50%. And that seems to be in patients who don't have an underlying cause of that secondary seizure. The seizure itself can cause secondary neuronal injury and worse outcomes, which is why there is an urgency and a sort of a pro in aggressively treating these patients. But unfortunately, there's not a lot of data on how to treat the treatment approaches for refractory non-convulsive status epilepticus, the choices of medications, the progression of IV anesthetics, which ones to choose. And so how aggressively you choose to treat depends on how likely the neurodeficit is related to the EEG findings that you are seeing, which often can be quite subjective. So the initial therapy I won't go over again, but it's a combination of the IV benzodiazepine challenge to see if there's a resolution of symptoms or if you have an EEG, a recovery of the EEG signal to more normal appearing or loss of epileptiform appearing signals. You choose, if you can, the non-coma inducing IV anti-seizure medications, in this case, there were several to choose from. And then you try to diagnose and treat the non-convulsive status very quickly and trying to avoid sedation. But in this setting, you already have a coma. This patient was intubated because of his comatose state, given 2 more milligrams of lorazepam and loaded with IV phosphonatone. The EEG was read by epilepsy there as unchanged and still concerning for non-convulsive status epilepticus, and the patient continued to be comatose. So not understanding what might be the etiology of this, IV lacosamide was empirically ordered, was given, head CT was ordered, and this is what they found, a normal head CT. The CSF the patient had the lumbar drain was sent from neurosurgery for analysis concerning for, this recent lumbar epidural abscess and concern for, meningitis or ventriculitis, some kind of an infection causing CNS abnormality, including non-convulsive status. The CSF profile return is non-inflammatory. IV midazolam was started, and a third anti-seizure medication was concurrently started. So at this point, the patient has a new onset refractory status epilepticus. This goes on for many days. This is an etiology where you have no etiology found for the first 72 hours without a pre-existing neurological disorder or prior known epilepsy. It's super important to try to identify and treat that underlying cause. And in this case, a CSF infection has been ruled out and imaging has turned back normal. And so, as I mentioned, typically those return to baseline are those that have the pre-existing known neurological disease and maybe some non-compliance in medication. So this patient represents that other side of patients who probably have a worse prognosis based on cohort examination. The new onset refractory status epilepticus in this patient continued to be managed by epilepsy, reading the EEG, neurosurgery, managing the drain, and the general intensivists who were managing the patient. The midazolam that was weaned, when it was weaned, the EEG would worsen with more rhythmic lateralizing epileptiform discharges, which is again concerning for non-convulsive status epilepticus by the epilepsy physician. So the midazolam was not only restarted, but propofol was added, and a fourth anti-seizure medication was added, valproate. At this point, with the two anesthetics, the patient became hypotensive and required IV pressors. As a result of the hypotension, pressor-dependent hypotension, acute kidney injury developed, the patient became oliguric, and continuous renal replacement therapy was begun. An MRI at that point was performed, which was read as normal. And the CSF was continually checked and was seen to be non-inflammatory. The lumbar drain site was noted to be clean and dry. And a conversation was had about de-escalating care and palliation. This patient, unfortunately, was at a hospital where his family member had been a prior surgeon. And so the family members, colleagues actually were recruited to help with this palliation discussion with the wife. The wife insisted on a second opinion and the patient was transferred. So a therapeutic diagnosis was made on an examination of the patient, the EEG, which was nonspecific, and the normal appearing CT scan, but on sagittal view of the MRI, the diagnosis was made with this history. The lumbar drain was clamped and removed. The patient was put in a Trendelenburg position, head down, stopped the propofol and midazolam, monitoring the EEG for recurrent seizures if that was indeed what was going on. The vasopressors were able to be quickly weaned off after IV anesthetic stopped, and this patient was awake with a normal neurological exam within 72 hours. So the diagnosis here is intracranial hypotension. This is a real patient that this actually happened to with a lumbar drain. One could argue that perhaps the lumbar drain should not have been left in for so long without a real reason for it. And I can't argue for that. But this can occur even in the absence of a known trauma, so in a spontaneous CSF leak. So it's important to recognize in the differential, just from the absence of sort of significant neurological injury on imaging and non-specific findings on an EEG. It's hypothesized that when the brain is bulging downwards or sagging as a result of the intracranial hypotension, the incisoral, I can't say this word, but the herniation from that intracranial sagging can lead to dysfunction of the thalamocortical pathways. And this is what leads to the disturbed consciousness, even including some myoclonic-like movements. It's even possible that on the EEG, it was in fact related to the brain sagging or the brain bulging downwards. because thalamic lesions in other cases can produce stimulus-induced rhythmic, periodic, or ictal discharges. It's important to think of this in the differential because clinical findings in intracranial hypotension can be quite vague. You can start with maybe a headache that is resolved with laying down. And you can imagine that that would be difficult to elicit it's just in any case, and that is quite an insensitive symptom because headaches are very common. An MRI, if these findings are existing, can lead to an early diagnosis of intracranial hypotension, but you really need to look at the sagittal view. None of these findings were seen on this patient except for a slight sagging of the brain and a tonsillar lowering herniation. But you can see there's an acronym called SEEPS, subdural fluid, pachymeningeal enhancement, which was not seen in this patient, engorgement of the venous structures. And in fact, that's oftentimes the only or initial finding, which can be very nonspecific and subtle. So if you don't have a pretest probability of thinking of this as a diagnosis, you could see that you would miss this diagnosis. And then a pituitary fullness or a hyperemia. So I want to pause there and then see if there's any questions or comments from the panel about this case.
I have a comment to make, Mr. Jean. So, how important was for the management of this case performance on MRI? Because the patients initially underwent a brain CT, but this did not help. So, how important is MRI versus brain CT?
Neither. If you can see a CT scan, a sagittal, and you see some of those subtle findings, you can consider this. I think in this particular case, we didn't repeat any imaging. In fact, the patient arrived and that was the action we took. Even without an imaging, that was the #1 differential diagnosis. It's easy enough to treat. And in this case, the MRI on review that had been read as normal was in fact not completely normal, but it wasn't a typical finding. Without the pretest probability was not noted by the neuroradiologist on the read. Does that answer the question?
I have another question, Sujin, if you allow me to talk about a clinical presentation. So usually in patients with intracranial hypotension, we see a difference in clinical presentation in the sitting and lying position. Were there any clinical findings which you recognized in that patient? Because that could be the straightforward diagnosis. And as well as Claudio said, I think it's very important to perform an MRI scan at this stage.
Yeah. So in this case, it was not our patient until they got transferred. So I'm not clear if there was an opportunity in that intercurrent half day when he might have complained of a headache, might have been relieved with lying down, which is a classic presentation of this syndrome of intracranial hypotension. In other considerations of spontaneous CSF leak, you can often elicit sort of a resurgence of symptoms of headache, nausea, with exertion, for example. And so that we didn't have the opportunity to do, but those are certainly questions that you might be aware of if you have that in your history to think about intracranial hypotension in your differential.
Very, very important point.
And another point, so CSF exam was normal. I just assumed that. I did not clearly hear that. This is important.
What was normal? I'm so sorry.
A CSF examination. So
yes, that was
right.
normal.
Although there was an epidural abscess and the post-operative stage, you had a normal CSF, because that's quite unusual to my mind, even after the operation. And I do not clearly see the indication for a lumbar drainage. Why this was performed in this patient, because this is, to my mind, not the regular care for patients with epidural abscess to leave this lumbar drainage in.
Agreed. And then I think when I think about this case, I often think about the elephant, where there are multiple blindfolded men touching the elephant, and you see an interpretation of the trunk as a tube and the leg as a tree, et cetera, and you miss the big picture. And in this case, unfortunately, it was taken care of a very good intensivist who tried to manage the symptoms in front of them and relied upon consultant care. I agree. I think I mentioned that I don't understand the utility of a lumbar drain in that situation, especially since it's a lumbar thing. You're not really worried about cord edema and trying to enhance perfusion or anything like that. But in that case, this is something to recognize. It's not needed. So it was very easy to clamp it and remove it. The cases that are reported in the literature, especially with this presentation of intracranial hypotension and the presentation masquerading as non-convulsive status epilepticus, are usually seen in spontaneous CSF leak, but will present very much with similar myoclonic-like movements, a progression to some degree of decreased consciousness, and then presentation on EEG of something that looks like non-convulsive status epilepticus, and that can be treated, unfortunately, for a lengthy period of time, delaying the diagnosis of a CSF leak.
Thank you very much.
Do we have time for a second?
Sure. For the second case, you mean?
Yeah.
For sure we have.
Is there questions on WhatsApp?
Please go ahead.
Okay.
I will address them all together at the end of the session. So
okay, great.
Proceed. Thank you. And
this one's a little shorter, so that's good. So this is a patient who is 60 years old with hypertension and diabetes, admitted for a GI bleed while on apixaban for atrial fibrillation. The apixaban is immediately, obviously not recontinued. Kcentra is given for reversal of coagulopathy and blood is transfused. Patient undergoes an endoscopy, which is unrevealing, but the patient becomes hemodynamically stable and does not have any further episodes of GI bleed. And so the GI service is hard pressed to try to do a colonoscopy on this admission and recommends, once the patient is more stabilized, to undergo further imaging in a future date. On the 4th day of hospitalization, the patient complains of dizziness, nausea, and headache. He's given ondansetron and acetaminophen, and eventually the symptoms do subside. So by the 5th day of hospitalization, the patient is now ready for discharge home and is taken off telemetry. And when his nurse goes to provide discharge paperwork, she notes that he is obtunded and intermittently apneic. So a code is called and his vitals are taken. He's still in atrial fibrillation. His rate is 89. His blood pressure is 170/80. And his oxygen saturation is around 80%. So on exam, he's noted to be nonverbal, does not open his eyes or have any motor response to noxious stimuli. His pupils are slowly reactive and his eyes are bobbing downward. And so he's intubated and a stat head CT is ordered. I'm going to pause here because maybe we could try to have a commentary on what's the next step here and what the differential might be. Anybody in the comments?
I see some arrive. Well, one point I can make is this is a very, very sudden occurrence of unconsciousness. So I wonder, was that functional due to epilepsy? So what will be the clues? Because we know not all epileptic forms are accompanied by clinical jerks, and so can be a non-convulsive status epilepticus.
Right. Absolutely. So that indeed is the differential, the sudden onset of a neurological decline. Of course, it was unwitnessed. So you have to include a very sudden onset ictus, like a vascular event, either blood in the brain or lack of blood in the brain, an anoxic brain injury while off of telemetry, maybe arrhythmia, who knows. It's unlikely given the stable vitals. So those are clues against that. And then finally, seizure is really high on the differential because we don't know if there was some focal onset that, kind of progressed to a non-convulsive status epilepticus as well. And so those are the three things. The clues here would be that the day before, there is a suggestion of some symptoms that actually turn out to be significant later, and that was the dizziness and nausea, which is often a heralding sign for what this ends up being. And then on examination, the non-responsiveness comatose state is certainly non-specific, but the fact that the eyes are bobbing downward later on will show you that it's not unusual to see this initially in this specific diagnosis. So again, the differential diagnosis here is stroke, seizure, intoxication of some kind, because we don't know what was going on in the patient's room, maybe from a medication that was given, maybe an illegal ingestion, which certainly we maybe have all seen, a catatonic state, or maybe even a functional diagnosis. This is the stat head CT's result. And when the family is notified, because his wife was getting ready to come and pick him up, his wife relates that she had just talked to him on the phone on her way to pick him up. But she comments that he seemed to be slurring his speech a little bit, and she thought maybe it was because he had just woken up. So the EEG is placed, it's normal, and the urine drug screen is negative. So your thoughts now?
Well, if I have to consider in a patient with atrial fibrillation a stroke, I would rather think that I will expect some focal signs to be present. Well, it's true that brain CT is negative, but if it is a stroke, it has just occurred. So the brain CT cannot be so sensitive in a very, very early phase of a stroke. So maybe a stroke is there, but I just cannot see it.
That's right. Absolutely.
So if I can discuss something, so I have a question. What about pyramidal signs? Were they positive or not in that patient? And you said that there was no movement to noxious stimulus, but was there any movement to pain stimulus or not? So do we have symptoms and signs in the clinical exam which point towards, and I would suggest, the midbrain or thalamic lesion, which is explaining the unconscious state and maybe also the pathology in motor response?
So there was no movement to pain and no extraneous movements noted.
So what about Babinski sign? Positive or not?
Was mute.
Mute. Okay, so pathologic.
Pathologic.
And so that's why we need a CTA if we want to stay with computed tomography, otherwise an MRI scan, but I would go for CTA first. And we see in the basilar artery, it's very difficult to differentiate in one slide whether this is calcification or beginning calcification or whether that's an obstruction and therefore basilar artery thrombosis.
So if you can see my arrow, can you see my arrow here? So I'm circling what is the basilar artery in an axial view that Raymond has astutely noted is a little bit bright and the color of bone. So it's either a calcification or a clot potentially, and it does align with the symptom onset of the anterior pontine and midbrain involvement potentially. That would explain the symptoms. So indeed, that is what this was. This was a basilar artery thrombosis, which is one of the things that neurologists are the most fearful of missing. So CT is not sensitive, as Dr. Sandroni really pointed out astutely, for early acute stroke in any area, but especially in the posterior fossa, which classically is very difficult to image for any meaningful detail with a CT scan. The hyperdense basilar artery sign, which Dr. Helbig really pointed out, well, it was seen, but it's only seen in about 50 to 70% of patients, so you can't really depend on this. So if you have a pretest probability of the symptoms and you see this, that can be very helpful and indeed can really move you towards either an angiogram or an MRI, depending on how much time you have and what your next step might be available to you. So MRI certainly is more sensitive for imaging ischemia or infarction in this region. Your suspicion must remain high so you don't miss this diagnosis. And I will just point out again, which I already did, the basilar artery, the dense basilar artery sign. So the treatment for this type of a patient is no longer coagulopathic, but it's unclear the source of the bleed. And unfortunately, because the patient was so stable hemodynamically and medically, the patient was about to be discharged without really knowledge of an ongoing source of lower GI bleed, and so would not receive an IV thrombolytic. But thrombectomy would certainly remain an option, especially given the time period and the decency of the CT scan to show us no evidence of significant stroke burden. So there really is hope for basilar artery occlusion. I mean, this patient ended up doing okay, actually was not comatose on discharge, and this was a good save, but you can imagine it going the other way, especially the patient was not in the hospital initially for acute stroke, but rather for a medical illness. And I will show you in a little bit on the next couple of slides about why that ends up being a problem. So there are a couple of trials that have been tried to be performed for the analysis of the basilar artery occlusions and the benefits of thrombectomy. They're really hard to enroll for. There's low recruitment. There's a lot of high crossover rate because it is such a devastating syndrome that oftentimes it doesn't feel like there's equipoise to randomize to no treatment. So in all trials, there's been non-significant trends for benefit. And in a more recent study, it showed an increased odds of functional favorable outcome with endovascular therapy, up to 24 hours of endovascular therapy offered for basilar artery occlusion. I want to talk a little bit about in-hospital stroke because this is actually a much more common phenomenon than you would think. As a single clinician, you might encounter this once or twice in your career, but over a hospital's lifetime, this happens quite frequently. The primary diagnosis of in-hospital stroke is primarily, as you would imagine, in a cardiac population, about a quarter. And it's not just in a cardiac surgery or a cardiac procedure, but therefore a primary cardiac event. Second most common are patients who are there for another neurologic or neurosurgical diagnosis or procedure. Third most common is hematologic or oncologic diagnoses, orthopedic, GI, and then a host of others. In-hospital stroke represents, depending on the series that you see, actually up to 19% in one of the more recent series of all hospitalized acute stroke cases. That means that potentially up to 1 out of 5 of the strokes that we'll be seeing in a hospital are ones that come in patients who are already there for something else. And it's probably under-recorded. So this is a patient who's hospitalized for something else. There might be in a non-stroke unit, most usually, and that can lead to a delayed recognition because the nurses are not primed to be screening for this. Perhaps the neurological checks may not be done. If your medication administration is happening, there's not a requirement, as there might be in like a neurological unit, for doing a neuro check, a quick face, arm, speech test. There's less complete stroke care for primordial prevention, for secondary stroke prevention. And in general, it's been shown that you have worse outcomes than the overall general stroke population, probably of a host of reasons that are mentioned here. Currently, the in-hospital acute stroke patients receive about 19% of them will receive IV thrombolysis, which is shocking. You would think that if they're seen, well, biggest reason for outpatient stroke patients not to receive IV thrombolysis is the time window of 4.5 hours. You would imagine you have a last known male, you're already in the hospital, steps away from the drug of choice. But what happens is you often have a contraindication to IV thrombolysis. So you would hope that those patients, if they have a large vessel occlusion, would be able to receive endovascular thrombectomy. And in actuality, 6% currently receive endovascular thrombectomy. The denominator of this is really unknown. Which of those patients have an LVO would be LVO or would be amenable to this. But compared to the population estimates, this is actually quite high. And it's been shown that these patients benefit once the stroke has been diagnosed to transfer to a stroke unit where you can follow recommended management, primordial prevention for secondary stroke prevention. It can improve mortality. And that is it. I welcome any questions about that case.
Excellent. Thank you both for these excellent presentations. Just to add something to make a quick comment to your case, Jean. So one point concerning clinical examination in that case, one suspicion that something to the brainstem could have happened was the fact that the onset was immediate. The patient had a very severe clinical examination with Glasgow Coma scale was 3. The pupillary response was severely reduced. There was a downward ocular bobbing that was also a hint that something wrong may have happened to the upper part of the brainstem. Am I right?
Correct. The pontine. Yep, the pontine region. Mm-hmm.
Okay. So while a supratentorial ischemia may have caused a much more prolonged deterioration, a slower deterioration, and focal signs. In this case, we have no focal signs. So you may start from the beginning. That may be something related to the brainstem, even if it's just a suspicion based on clinical examination.
This is a very extreme case that represents the worst in terms of the presentation of a basilar artery thrombosis. But there are a significant number of basilar artery thrombosis strokes that don't present so extremely. So many can present, and you're given an opportunity to recognize that this and actually localize it to the basilar artery. And those symptoms are usually dizziness from a cerebellar infarct, or unilateral arm or leg or face, arm, and leg weakness. Dysarthria is very common, so slurred speech, as the wife noted on the phone.
Yes.
And some of these can be stuttering in onset. So when you hear in a history any type of combination of those kinds of syndromes, you can suspect that this is on your differential. In this case, most likely what was happening was that the day before had a symptom, that's not an uncommon thing to have a little bit of dizziness that can come and go, and then have a little bit of stuttering weakness. In this case, it's dysarthria, and then was unmonitored, right, in a non-neurological unit, and then progressed to the most extreme form.
Yeah. Well, dysarthria can be a sign of left-sided ischemia. So probably, does dizziness add something as a differential diagnosis versus a dysarthria due to the frontal ischemia in that case?
Mm-hmm.
Apart from the disorder of consciousness, I mean.
Right, was it a comment or? Yeah.
Yes, please go ahead.
It was more of a comment than a question, I think.
Yeah, no, my question was, in that case, did the presence of dizziness add something to the diagnosis vis-a-vis the differential diagnosis of a left frontal ischemia in that case? Because slurred speech may also be a sign of a supratentorial stroke as well.
True, although dysarthria would be difficult to localize to a supratentorial infarction. So if you have dysarthria, you usually have significant hemiparesis alongside of it. If you want to localize it, you can say it's a lacunar stroke and would be deeper. It would be deeper than just certainly supratentorial is possible, but not a cortical, large volume cortical stroke. I think the combination of the dizziness, which is quite unusual for a supratentorial stroke, would have really pointed you towards the brainstem.
Yeah. Excellent, thanks. Another comment is that in that case, the diagnosis could be made relatively easily based on the brain CT, because we have a hyperdense vertebral artery. But as you correctly pointed out, this sign can be missing in a remarkable percentage of cases. In that case, I'll tell you what I'll do. I will perform a contrast brain CT. Will that be helpful in that case?
With angiographic imaging, like a CT angiogram?
Correct, angio-CT.
Yes, possibly. I think given the profoundness of the patient's presentation and the differential that you had with the CT, you might actually find situations where they would be willing to do an angiogram right away to treat. But I agree with you, most likely they would want a CT angiogram, which is also quite fast, prior to going to an angiogram.
Yes, you are already on the CT theater, and there is the basal artery may look normal or quite normal. I will ask you, in that case, will it make sense to proceed to the angio? We'll take a few additional minutes and give you an initial workup.
I think an
yeah.
important point that you're sort of saying by omission is the preference for a CT angiogram over an MRI, which I completely agree with, because an MRI here would probably, in most cases, slow down the process rather than speed it up. And you have a relatively good window of time to say, you don't really need a tissue perfusion clock. You need just the presence of the LVO. And you have a CT that already shows, even though it's a suboptimal scan to use, that the tissue is not relatively damaged. And there is, I guess we can mention the posterior circulation aspect score, which does exist, and that's the Alberta stroke, I forget what the PECs mean, but it's a staging scale using CT scan. And there's an anterior one that's used for high risk, most benefit for anterior circulation strokes, but there's a posterior circulation version of that as well. It's a 10-point scale, as you know, and it takes points off for the involvement of things like thalamus, internal capsule, brainstem pons, midbrain, cerebellum, and that the higher the stroke, the higher the aspect score. In that case, I believe it's 5 or greater for the posterior circulation. You would think that it could potentially be beneficial to go for thrombectomy.
Okay. But as I see it, it's very important to underline that a sudden and very important deterioration of consciousness can be either caused by a vast supratemporal lesion or a relatively small lesion, but in a critical point of the brain, which is upper brainstem. Is that correct?
That's right. I mean, I guess, I suppose another imaging you could have discovered, and I would be interested to hear what you guys think, is if there was a massive supratentorial ICH with herniation and like a Duret hemorrhage, and potentially would that also, and that would have been unwitnessed over maybe an hour or 2 or 3, and potentially would that be also an examination that could be found? I wonder, I think the pupils would probably be fixed at that point, but you would have a similarly devastating looking exam. But certainly speaks to an ictal event of stroke.
Okay. There are some questions from the floor. I don't know if we have time to address it right now. I'm asking to the management in the studio. If not, I have a question for both of you, starting from Raymond. Raymond, are you still online? He's not at the moment. So I have a question regarding the management of status epilepticus. We have seen in this case, in the first case you presented, Sajin, that the family was considering, or the family and the doctors were discussing treatment limitation in that case, palliative care. But I wonder if it is appropriate to discuss palliative care when the prognosis, while the prognosis of the status epilepticus has not been finalized yet. Because while it's true that status epilepticus has a very poor prognosis, we have seen the result of recent trials, for instance, in like the Telstar in post-anoxic status epilepticus is massive ischemic brain injury from cardiac arrest. But in that case, where you don't have a diagnosis, what are the chances that status epilepticus, even if refractory, can have a good outcome?
So I wanted to point that out as a really important part. So thank you for bringing that up, because absolutely the patients we have seen with new onset refractory status epilepticus that require that depth of aggressive treatment for weeks, if not months, can actually have a good outcome. And so to start discussing palliation and withdrawal of care, especially when you don't have a true understanding of the underlying etiology, is wrong, in my opinion.
Okay. Yes, for me as well. Okay, very good. Okay. Thank you very much, Sajin, and thank you for Raymond, who had to leave the webinar early. It has been a fantastic session with very, very interesting cases. That the session will be recorded, so you can see. We will be soon able to see it again anytime. Thank you for those who participated in this webinar. Thank you for you at home or at the hospital, wherever you like. Thank you to ESICM for having supported this webinar. And have a nice day or night from Claudio Sandroni and ESICM. Bye.
Bye-bye.